Hello, everybody, and welcome to August's edition of St. John's Cancer Institute's Be Inspired Speaker Series, Melanoma and Skin Malignancies. My name is Jean Goldsmith, and I'm a Director of Development at St. John's Health Center Foundation. As many of you know, in January of 2021, the Cancer Institute's name changed to the St. John's Cancer Institute. The licensing agreement allowing St. John's to use the name and likeliness of John Wayne on the Institute and the fellowship program expired at the end of 2020. The change is a name only, and it will not impact the Institute's operations in any way. And the fellowship program will now carry the name of the physician who founded the Institute and be called the Donald L. Morton Complex General Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research, education, and cancer care through innovative clinical trials and laboratory research, the education of the next generation of surgical oncologists and scientists, and of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen the focus of our main pillars of cancer research: immunotherapy, molecular medicine, and genomics. Before we get started today, I have a few housekeeping items. We would love to hear from you, and we're hoping that you will ask questions during the webinar. As you will notice, everybody but the presenters are muted so that we will all be able to hear them well. In order to ask questions, we would need you to use the chat function on your screen, and the chat function looks like a thought bubble. It's found at the bottom of your screen. So please go ahead and type a question in. Dr. Martin will see that question and ask the physician. If we don't get to your question during the webinar, we'll follow up with you in an email with your answer. And if you have an answer, if you have a question after the webinar, please email us and we will get that answer to you as soon as we can. You can communicate with us by replying to the emails that we have sent to you. We have a very interesting hour in front of us as we will hear from a medical oncologist and two surgical oncologists who focus on melanoma and other skin cancers. They are clinicians, but they're also researchers, and they work closely with our immunotherapy, molecular medicine, and genomics research labs, and through collaborative research have made great inroads into the treatment for malignant skin disease. I'm very honored to introduce the panel today. Dr. Kim Margolin is a medical oncologist and co-director of the Melanoma and Cutaneous Skin Program. Dr. Margolin came to us recently from the City of Hope, where her treatment and research in melanoma and immunotherapy, and her leadership in the Cytokine Working Group and the Cancer Immunotherapy Trials Network has made her a hugely respected clinician and researcher nationally. Dr. Margolin will collaborate with surgeons and laboratory investigators at St. John's and will lead the Institute's efforts in therapeutic trials for advanced melanoma and other cutaneous cancers. Dr. Margolin, what excited you the most about your move to St. John's and our melanoma program?
What excited me the most was the opportunity to do essentially what I know how to do, and to do it in a place where the sort of blend of translational science, interaction with a multimodality group, mainly surgery, surgical oncology, that is heavily dedicated to melanoma surgery, and to be in a place that was different in size and shape than the place that I had just been for about 30 years, along with a couple of other larger academic institutions, which were also a lot of fun, but I guess I like change as well. So there's a lot of comfort in doing what I know how to do the best, and there's a lot of fun in working with the types of people and the individuals with whom I hadn't had the opportunity to work before.
That's great. Well, thank you, and we're so excited to have you, with us, and look forward to the future with the work that you're doing here. Our second panelist is Dr. Trevan Fischer. Dr. Fischer is a surgical oncologist and the Assistant Director of the Donald L. Morton Complex General Surgical Oncology Fellowship Program. Dr. Fischer's clinical interests are melanoma and other skin cancers, breast oncology, and soft tissue sarcomas. He's interested in advancing the science of minimally invasive surgery and uses these interests to advance the training of the surgical oncology fellows. Dr. Fischer, as a surgical oncologist and the lead of our fellowship program, can you tell us how your fellowship experience here influenced your focus in melanoma?
Sure, thanks, Jean. We train our surgical oncologists to be broad and covering multiple disease specialties throughout their training. When I came to the Institute as a fellow in 2015, the depth and the level of research, clinical trials, and clinical care that our program provides our trainees really garnered my interest for doing this as a career moving forward. So I think the experience that I had as a fellow really sort of catapulted me to the career that I'm doing now, and I'm happy to be able to do both education with training our surgical oncology trainees, as well as collaborate with world experts like Dr. Margolin and Dr. Essner.
Great, fantastic. Thank you very much, Dr. Fischer. And our third panelist today is Dr. Richard Essner. He's the Director of Surgical Oncology and the co-director of the Melanoma and Cutaneous Skin Program. Dr. Essner was a fellow here at the John Wayne Cancer Institute and was trained by the founder of the Institute, Dr. Morton. Dr. Essner, you've been a melanoma specialist within surgical oncology for years. What changes do you see in this field, and what excites you about caring for patients in the future?
Well, I want to first say thank everybody for spending time with us today. We are certainly in an era of innovation, and we see it all around us in our whole world. And in the world of melanoma, we see it too. And so development of new therapies, which have been based upon better understanding of the molecular mechanisms of cancer, has allowed us to really expand upon really great treatments, and has made surgery really kind of have a component of cancer care. Whereas when I first started, there was no good therapies, and we depended on surgery for taking care of our patients throughout their disease courses. So modern innovation has really changed our world and has really made it very exciting for all of us.
That's great. And you've really seen an amazing revolution in the way that we've treated melanoma here, especially here. It's been probably a fun ride for you, I can imagine. So that's great. Moderating today is Dr. Neil Martin, the Interim Executive Director of the St. John's Cancer Institute. Dr. Martin is a neurosurgeon and is also the Regional Medical Director of the the Regional Medical Director of the Neuroscience for Providence, Southern California. He oversees neurosciences for Providence hospitals and clinics all across Southern California. Take it away, Dr. Martin.
Well, Jean, thank you. And I want to thank the panelists for joining us today and to welcome the large audience we have out there. It's a great opportunity for us to give you some updates on the treatment of skin cancer, and particularly melanoma. And it's particularly appropriate that we're really here at the home of the modern treatment of melanoma at the St. John's Cancer Institute. It's a real privilege for me to be able to participate with the world-class clinicians and scientists and surgeons here. And so we'll get some input right from the front lines of skin cancer treatment. Dr. Fischer, can you kick it off for us? How big a problem is skin cancer? How common is skin cancer? What are the various types of skin cancer?
Yeah, so we think broadly about skin cancer as a whole. It's the most common cancer out there, and that's mostly because the basal cell cancers and squamous cell cancers are so frequent. About 1 in 5 Americans will have one of these, so they're very common. The more aggressive, more deadly cancers that we sometimes see are much less common, thankfully, and so we certainly want patients to be aware of these risks and have the ability for skin checks with their physicians to be able to diagnose these early.
Well, terrific. Thank you. Dr. Margolin, tell us a bit about the progress of melanoma. We know that this is a serious cancer, a deadly cancer, and it's one that can come back after treatment. Why might it come back?
So melanoma is, I mean, it's like a lot of other cancers in being wired molecularly in a very, very complicated way. There are many genes that can give rise to other genetic material that ultimately leads to the proteins, the material inside cells that tell the cells how to function and what to do and where to go and how to interact with other tissues. And I'm not going to say that melanoma is more complex or more aggressive than other tumors. It certainly is more than other skin tumors. And it is capable of invading through barriers and going through blood vessel walls and breaking through and sticking to things and moving on to other places in a way that is quite efficient and is able to evade many of our therapies or our abilities to find it.
Okay, and Dr. Essner, if someone has a mole on their skin that looks worrisome, what's the process? If somebody's worried that it might be melanoma, what do they have to do?
The first thing they should do is go see a physician if they have concern. So there are things that we try to educate our patients about, changing in appearance, a mole that looks like it's growing. If you've had a prior skin cancer, that's of concern. If you've had family members with melanoma, that's also a little bit of concern. But the best thing to do is simply to go see a trained physician, either a family practice doctor or a dermatologist, and get it evaluated. And the dermatologists have a number of different techniques that they can use to kind of determine if a skin lesion needs to be biopsied.
And so biopsy is the fundamental diagnostic test, I guess, after a careful inspection of the skin lesion.
Yeah, so again, there's a number of different techniques. Dermatologists start off with very simply using lights. They can use magnifying lenses. There's something called epiluminescence, where they actually take a lens and put a drop of oil between the lens and the skin. And then there's something called confocal microscopy. And these are all techniques to try to guide the dermatologist in which skin lesions to biopsy, because even in the best of hands, a dermatologist in general, out of every 10 things they biopsy, only one of them is cancerous. So they have a very high level of biopsy, but as you can see, they're wrong in 90% of the cases. Of course, it's important to understand if something is benign. More recently, there's a number of different companies that have been trying to develop non-invasive techniques. There's one company that developed a tape test, which is very simply you apply this sticky tape to the skin lesion, and it actually pulls off some of the cells and allows them to do some molecular testing. And it has its advantages and disadvantages, you can imagine. Depends on the surface of the skin. There's a bunch of hair there, skin oily, but they've advocated that this is a non-invasive method, and more of these type of tests are continuing to evolve in research facilities.
Dr. Fischer, we hear a lot about genomics revolutionizing cancer treatment. How does genomics interact with skin cancer?
Well, I mean, you're right. I think as we advance our knowledge in across all cancers, we want to sort of personalize how, what risks are there with each individual patient. Genomics can change sort of our knowledge of the risk of metastasis or the risk of the cancer spreading to other areas and the risk of it coming back. And so these techniques are being used and sort of being studied currently across the world to determine if we can get this information from the upfront biopsy, how may that help us guide therapy? Should patients have more aggressive surgery? Should they be screened in a different way? And so some of these things are still sort of ongoing, and we're learning more and more about these each week.
And Dr. Essner, when that biopsy or the other tests strongly suggest that an individual lesion is melanoma, what are the steps in evaluation and treatment?
So again, melanoma is still considered an unusual disease. And so being sent to a surgical oncologist or a specialist in melanoma, The patient needs to be examined to make sure there's nothing else on the skin, evaluating lymph nodes, because melanoma, its first place it typically travels to is lymph nodes. And so they need a thorough examination. We do x-rays. There is no particular blood test for melanoma, although in general we do blood work. And so again, a thorough evaluation by somebody that cares for melanoma really on a daily basis is important, because this disease has kind of an unusual pattern can have unusual patterns of spread. And again, you need people that kind of understand that. And also you need somebody like Dr. Margolin in the back line to be able to help take care of these patients if they develop spread of disease.
And Dr. Fischer, what treatments are generally recommended for the other types of skin cancer, squamous cell, basal cell cancers?
Yeah, so with any skin cancer, catching it early, usually, as Dr. Essner mentioned, is usually a surgical, the next steps are usually surgical. We use a technique called the wide local excision to ensure negative margins around the cancer. And so usually the cancer is a defined area, and we take more tissue, sort of normal tissue around that space, and send that off to the pathologist. In melanoma, we also, in majority of the cases, we also test the lymph nodes or the draining lymph nodes at that time. In the non-melanoma skin cancers like basals and squamous cell cancers, that is done much less frequently, because the risk of cancer spreading from the primary area to the lymph nodes is significantly smaller, and that procedure does not yield as much as it does in melanoma. Or cancer we haven't mentioned yet today would be Merkel cell cancer, which is even more rare than even melanoma. It sort of has an aggressive pattern as well.
Okay. How often, Dr. Fischer, is the surgery for melanoma for a mole that's melanoma? How often is the surgery curative?
It's all about sort of what the surgery finds, right? So if we catch at an early stage and the lymph nodes are negative, 97 to 99% of those patients are finished with surgery and just go into a surveillance pattern. The more the tumors are, with the information that we can get from the biopsy and couple that with the surgery, there are some features that may be a more poor prognosis in those patients, and they have to be followed in a different sort of mechanism.
Dr. Margolin, which patients should have additional treatment after surgery?
Patients who should have additional treatments after surgery are selected based on prognostic factors or factors associated with the tumor that's removed, with or without lymph nodes removed, that are associated with a higher chance of relapsing. And those would include patients whose tumors are fairly deep when they're taken out ultimately by the surgeons, those that have an ulcer on the skin, in other words, a break in the surface of the skin that occurred while the tumor was growing, and those who have one or more lymph nodes involved with anything more than just a tiny microscopic focus of tumor cells in the node. Those are the ones who can benefit from additional therapy after surgery.
Okay. And what are the most common types of additional treatment that are recommended for those patients?
So there's two common general types or categories of therapy, and they depend in large part on whether the tumor, when it's sent to a special lab to analyze its chromosomes, its DNA, genetic material, has a particular mutation that is associated with propelling that type of melanoma, its growth and its proliferation and its resistance to death. So those patients may be recommended to receive oral pills that interrupt that particular mutated pathway that can, when those pills are given, they can cause the tumor to stop growing and die. Or for some of those patients, and for those who don't have the mutation, we recommend immunotherapy, which is a way of killing tumor cells by stimulating the immune system, usually lymphocytes or T cells, to respond against cancer cells rather than giving a treatment that directly hits the cancer cells themselves.
And we hear a lot about clinical trials and new agents that are being investigated. Under what circumstances should someone consider entering a clinical trial?
Assuming this is mine.
Yes, yes.
So I would say, it's easy for me as a clinical investigator, a lifelong career clinical investigator, to quote what's on every page of the National Comprehensive Cancer Network, that is, every patient should be in a clinical trial, or the best treatment for any patient with cancer is a clinical trial. Because the fact is, that's the only and best way we can learn from every generation of patients to come up with the best therapy for the next generation of patients. The only patients we don't even consider clinical trials for are really the ones who medically do not fit the categories that are somewhat strict, so that we can maintain safety and we can avoid confusion of the data. For example, if a patient has 2 or 3 different malignancies, or severe heart disease, or has a stroke, or has severe diabetes or autoimmune disease, then those patients are generally excluded because it's hard to safely place them in trials and to analyze the data that come from their participation. Just about everyone else should be.
Okay, thank you. So, Dr. Fischer, I know that you've done quite a few scientific studies on patients with COVID over the last year or so. How does COVID interact with either cancer itself or with the treatments for cancer?
Yeah, so I think there's sort of 2 parts of that question. One is viruses and cancer treatment sometimes fall along the same pathway. So some of the medications that we've actually studied and used in COVID started off in cancer patients, and so there's a big overlap in that, and I think that's certainly helped as the pandemic has changed, so frequently, so rapidly, and sort of thrown curveballs around every corner. We've already had some sort of drugs that are available to be able to combat this. So I think on that level, there's a lot of overlap, and that's why our Cancer Institute, when COVID started and started affecting our patients, not necessarily our cancer patients, but our community, we were able to jump in and sort of transition to providing clinical trials for COVID patients through the hospital, even as an outpatient. And I think it's made a huge, impact. Our institutions enrolled probably over 200 patients and still have some ongoing trials looking at newer, more novel therapies for how we can improve COVID patients. On the other side of that, sort of COVID and cancer patients, if we combine the 2 of them, thankfully for the melanoma patients, most melanoma patients are not on therapy that wipes out their immune system, right? So like other cancers, a lot of times they're immunocompromised because of their treatment. And obviously any infection, no matter the common cold, coronavirus, or anything, poses a higher significant health risk for them. For our patients, we take extreme precaution no matter if they're under active treatment or not. We've all practiced our wearing our PPE in the hospital and clinics, and thankfully have not had a lot of patients on active therapy come down with COVID. So I don't know if that answered your question or not, but it's definitely posed lots of challenges to the health community as a whole, and also to the cancer community.
Right, certainly. Thank you. So, Dr. Margolin, I want to follow up on some of the issues around additional treatment, because we're getting some questions texted into us. One question coming from Carol. What are the currently approved and available immunotherapy drugs for melanoma?
See if I can remember them. There's actually not that many of them, and we have some overlap. So actually, there's an old drug we don't use anymore. It was not very potent and it was very toxic, but it sort of set the stage for the newer immunotherapies, and it was called Interferon. It's very interesting in immune studies, but it's not therapeutically really very beneficial or safe these days. The current ones started with a drug called Ibulimumab or Yervoy in around 2011, which had modest activity against melanoma and moderate safety. After that came two drugs that are almost identical, and they can be either given alone or combined with Yervoy. One is called Keytruda or Pembro. The other one is called Opdivo or Nivo. Those are nicknames. And those drugs are much more, about twice as active as Yervoy and about half as toxic or less than Yervoy, and unless you combine them, which we often do in order to get the best therapy outcomes. There's another drug that's an immunodrug that's approved in combination with some of the BRAF mutation drugs that I mentioned earlier, and that's called avelumab. And I'm sorry, not avelumab, but atezolizumab, or what is the trade name for that one? I can't remember, but that's we tend to use the generic names. And is there any other immuno? There's another drug which is actually an injectable that we use directly going into tumors called Tvec or Imlygia, which is a genetically altered herpes virus that carries an immunologic drug in its DNA, in the virus. And when you inject that into the tumors, they often become immunologically very active and inflamed, and they induce other immune cells to come into the tumor, which can cause the whole body to become immune to the melanoma.
Okay, that's great. Thank you. We have a question from Scott that's related, and that is, what are the key side effects that are associated with immunotherapy?
So in a sort of as a general statement regarding that, the side effects from the class of drugs that we're now using most for immunotherapy are those which are associated with sort of an overstimulation of the immune system. And when you do that, while the drug is supposed to be stimulating the lymphocytes, the T cells, to recognize and kill tumor, sometimes the T cells lose their ability to discriminate tumor cells from normal body cells. And they give rise to autoimmune diseases that are similar to diseases that people get anyway, such as colitis, which is inflammation of the bowel with severe diarrhea and cramping sometimes, or skin rashes, or thyroid disease, much less commonly liver inflammation or other organs that can become inflamed, including dangerous situations like heart inflammation, which is extremely rare.
Okay, thank you. Dr. Essner, there are a couple questions about the surgical approach. Are there circumstances in which there are upfront medical therapies or other kinds of treatments before the definitive wide excision surgery is done?
So for early stage melanoma, not yet. Stay tuned for that because it's evolving. So the idea being, as Dr. Margolin's talked about, is immunotherapy after surgery or replacement. There is scientific belief that actually adding immunotherapy before surgery might even work better. But right now it's at its infancy. It started off with people that show up with enlarged lymph nodes and are thought to be difficult to surgically remove. And studies suggest that giving either 1 or 2 doses of immunotherapy before the surgery will actually make the surgery easier, and the patients actually do better. So I would say stay tuned because we'll probably have some answers to that in the next couple of years.
Right, thanks. So Dr. Essner, a question came in for you from Janice, and that is, when a person is diagnosed with melanoma during a primary care skin check with a dermatologist perhaps, or a primary care physician, when should the dermatologist make a referral to a melanoma specialist? Do you see patients who you think would have had a better outcome if they were referred earlier?
Well, that's a difficult one because again, melanoma is still an uncommon disease. And we think it's best taken care of centers that take care of melanoma on a daily basis, centers of excellence. There are patients, as Dr. Fischer has said, that do well just having excision alone and nothing else. But until the process occurs, the evaluation, it's really difficult to say. But we would hope that every melanoma patient in the country would be seen by a melanoma specialist along the course of their disease and hopefully early on.
Okay, very good. Dr. Fischer, are there advances that we've seen over the last few years or underway now that relate to innovations around the way the surgery is done? Dr. Margolin mentioned intratumoral injections at the time of surgery, presumably. Are there any other surgical innovations that we should know about?
Yeah, so I mean, I think we as an institution really changed the way the upfront surgery is done. So there were two large a multi-center trial enrolled thousands of patients, which sort of before the early 2000s, most patients would have their lymph nodes all removed at the time of surgery. And as one can imagine, that's a much bigger surgery. A lot of times it means staying overnight in the hospital, more complications, patients have drains. So not a surgery that people can recover easily from, but a much more morbid procedure than what we do now. And what we found through these trials when we compared those who had just the sentinel nodes or the first line of defense nodes taken out, which is where melanoma goes to first in the majority of the case, not everyone, but in the majority of the case, we were able to do a much less morbid surgery, an outpatient surgery. We were just removing a handful of nodes, 1 to 3, 4 maybe, instead of the whole entire sort of nodal basin. And then that was followed on by a surgery to look at if those lymph nodes were negative, up until 2017, the standard of care would be to go back and then remove all the rest of the lymph nodes. And what we found through studies and a second study done out of Europe also sort of agreed with our study that we ran, showed that there was no survival advantage in doing the bigger surgery even after a positive sentinel node. So we've really minimized how much surgery we do in these patients, sort of similar to what we do in breast. So in breast cancer, we used to take the whole breast, part of the pec, and it was a very sort of morbid procedure. And now we're able to really minimize how much surgery we do in cancer while not really sacrificing any cancer outcomes. So the outcomes are just as good, if not better. And then I guess real quick about the TVEC. So TVEC is actually done, the intratumoral injections are actually done in the clinic. So whether it's injecting a lesion on the skin or using an ultrasound maybe to inject a lymph node or something deeper, that can be done both before surgery and in the setting of a recurrence or a tumor that may be resistant to the treatment on patients who sort of are getting other systemic treatment.
Okay, thank you. Well, we're getting questions about additional questions about follow-up after surgery. First is when is imaging useful in following a patient after surgery or determining what kind of therapy is indicated for surgery or indicated for additional treatment? Dr. Essner, what about PET scans or other imaging studies after surgery?
Yeah, so we typically use PET scans in our practice once we've demonstrated some kind of spread of disease. So for instance, as Dr. Fischer was talking about the sentinel node procedure, so if you're found to have a metastases by the sentinel node procedure, then we employ PET scan. We often use PET scan in people with advanced disease to kind of guide us to what to do next. And then in the world of surgery, it's been used to try to demonstrate people that have surgically resected disease versus not. So there's a number of different modalities using PET scan. Certainly it's not a replacement for all other type of imaging, and certainly it's not a replacement for actually examining patients. So PET is very useful. In our practice, most of the time when we have patients that have negative lymph nodes, that is the lymph nodes don't have cancer, we rely mostly on examination and a chest X-ray, because unfortunately, one of the places that melanoma can arise is in the lungs. And as you can imagine, their patients are not symptomatic until something in the lung gets quite large. So, but there's actually a lot of controversy of imaging and cancer, and we could talk about that for a whole day.
There are some exciting advances going on there. Dr. Fischer, a question from Danielle. After having had treatment with liquid nitrogen cryotherapy, I presume, on a small sunspot on the face, a new scab appeared above that area. How long should somebody like that wait before revisiting with their dermatologist, and why might that happen?
Yeah, so I mean, it could be coincidental that spot was going to occur there, regardless of how the spot adjacent to it was treated. For things that sort of arise like that, if they persist longer than about 3 months and they don't sort of take care of themselves, I think it warrants an evaluation. A lot of this also goes into sort of what your overall risk is as well. So if you have if your risk is really high for skin cancers, albeit lots of sun exposure as a child, blistering sunburns, sort of your hair color, your skin color, how much you're out in the sun, really, I would have a lower level of suspicion to do a biopsy of that area. But most things that are sort of that grow in the skin are a little scaly or flaky. A lot of those are just called actinic keratosis, and sometimes those can also be frozen and treated. But anything that's worrisome, a biopsy, I think, would be a very reasonable next step. Things that don't go away, I always tell patients, things that go away usually aren't bad. Things that persist, should warrant either close follow-up with serial pictures or serial exams, or more frequently, just a biopsy.
Okay. So Dr. Margolin, we're getting a lot of questions about prevention of melanoma or about who might be most at risk for melanoma. Can you talk about what the risk factors are in a patient who doesn't have cancer for getting malignant melanoma, and what they might do to prevent it?
I can try to talk about it. I'm not sure how gratifying it will be because this is an area where we're still very much, no pun intended, but very much in the dark. So if you stay in the dark and you don't go in the sun, your chance of melanoma will definitely go down, and your chance of non-melanoma skin cancers will go down dramatically. But that's like your whole life. That's not just, this week. Sunscreens, of course, are very important, and they're touted, and it's very important to have them include both UVA and UVB because the wavelengths are different from each other, and they have different impacts. The way that the sun contributes to the development of skin cancers depends on the type of DNA damage that it causes, and that's different and how the cells repair the damage and whether they do. So back to the question of preventing melanoma. Prevention of melanoma with sunscreen is very modest, but it's important because it preserves your skin and it prevents other skin cancers. The rest of it, you can't really do anything about. You're born with the genes that you inherited from your parents, and your hair color and your eye color and your skin tone and your ability to tan and your propensity to freckle. Those things are all connected to your risk of melanoma, but there isn't one factor that says, yes, you're going to get it, or no, you're not. Similarly, there are rare instances of familial genetic predispositions that can cause, many members of a family to develop melanoma. And it's good to know about, except that, again, there's very little that we can do about it other than what people should do anyway, which is to keep a close eye on moles for change, for what Dr. Fischer was mentioning. Anything that changes and persists is higher risk than something that goes away or doesn't change. So a good relationship with the dermatologist, if you have some of those risk factors, is important. There are a number of research labs trying to find chemicals that you can either put on your skin or take into your body or spray or bathe in, whatever. But so far, nothing has really stood the test of time, and so we're still looking.
Okay, thanks. Dr. Fischer, you're heavily involved with our surgical oncology fellowship, where young surgical graduates are taught the principles of diagnosis and management of cancer of various types. Can you tell us a little bit more about the fellowship here at the St. John's Cancer Institute, its history, and how they interact with the clinicians, the surgeons, and the researchers here?
Yeah. So, since Dr. Morton started the fellowship program in the early 90s, there's been I think we're up to over 170 now surgical oncologists that have graduated, 2 of which are on the call. So Rick, as mentioned earlier, was trained with Dr. Morton. I unfortunately never had a chance to meet him. So we have, these are all general surgery trained physicians. So they finished their general surgery residence. They could go out into the world and take care of cancer, take care of, any general surgery problems, but they choose to spend 2 years sort of diving into the multidisciplinary treatment of cancer. And these aren't just, random, sort of standard cancers, although we definitely see many of those. These are complex cases that really require, collaborating with radiation doctors, with geneticists, with medical oncologists, all the above to really figure out what the best plan for these patients are. Some of the easy, straightforward cancers, like we mentioned earlier, you need surgery and somebody to follow you up, and that's it. But there are certainly more nuances to, and the other piece of that is as treatment evolves, it's very important to sort of be abreast of what's new, what's coming out. And I think that's where how we train our fellows to stay up on the latest. And sometimes, to be honest, our fellows teach us some of those things because it's a very rapidly evolving field. We really want our trainees to not only be able to lead multidisciplinary tumor boards at whatever facility they go to, but also to be able to collaborate with the scientists, whether that's here during their 2 years or where they land up and start their career. I think that's how we make advances in cancer, is seeing things in the clinic and seeing how we may observe patients presenting a certain way and go back to our scientists, our colleagues, and really ask the question, and maybe they'll be able to help us figure that out. But it really takes that collaboration, and I think that's something we emphasize during our training, is to collaborate with the multidisciplinary teams to provide best cancer care, as well as collaborate with scientists where they are to be able to answer clinical questions that will advance the field.
Thank you, and thanks for all the great work you do with the fellows and the training program. Dr. Margolin, I want to follow up on the discussion you had about screening for skin cancer. Ali has a question. Do moles at birth present a high risk of becoming skin cancer? How often do routine skin moles need to be evaluated carefully by a dermatologist?
So with the disclaimer that I'm not a dermatologist and I practically never see melanomas in place, or what we call in situ, because usually they're gone by the time I see the patient. There are a few types of moles or pigmented disorders that are present at birth that might increase the chance of melanoma developing later. There are congenital nevi, congenital blue nevi that are enormous. They cover a large part of the body, and they can, if left unremoved, eventually over time, they do have proliferative cells in them, and with enough proliferation, there will be mutations, kind of like the coronavirus. If you give it enough chance to grow and replicate, it will mutate, and then the mutation might confer an advantage that looks malignant. So yes, but not common. For ordinary moles, most infants are born pretty much devoid of moles or with very few, and they're very tiny. We develop moles over time. Again, sun exposure is a likely cause. And, the vast majority do not ever become malignant. But again, it just boils down to change or evolution with the ABCDE approach. It's that E for evolution that is what you need to watch out for, regardless of what type of a mole it is and the related risk that is conferred by that.
Okay, thank you. So Dr. Essner, we're getting more questions about the treatment of squamous cell and basal cell cancers. Could you make some comments about how those are generally treated?
Yes, so the squamous cell and basal cell, I think Dr. Fischer alluded to, rarely ever spread. So the advantage to those tumors is that they really only become a local problem over time. And so there's a number of different modalities that we use. So number one is surgical oncologists. We do conventional excision. So we just excise the tissue. There are something called Mohs surgery, where a dermatologist will take layer upon layer and evaluate the pathology in real time. There's even methods of what we call curettage, where they'll just kind of scrape it out and then excise a little bit more. There's even a topical medicine for basal cell carcinomas called Aldera. And then finally, radiation is used. These tumors are very sensitive to radiation. So in a patient that's not a good candidate for one of the other treatment modalities, radiation works quite well. We have some patients with very advanced squamous cell or very advanced basal cells. Again, they're not very common, where we don't believe surgery alone is effective. And so we do surgery and then follow it up with radiation.
Okay, thanks. Dr. Margolin, we're starting to hear about blood tests for cancer. What's the role of blood tests or the so-called liquid biopsies for melanoma or other skin cancers?
So leaving other tumor markers aside, because that's really a different question, the so-called liquid biopsies refer to assays that test the presence and the quantity of DNA or genetic material from particular tumors in the blood, and have in large part been associated with the likelihood of a tumor either relapsing, or if you're treating somebody with advanced disease, giving you a sense of whether the tumor is shrinking or dying in response to therapy, or growing and living despite therapy. Those assays basically look for either mutations or features that are present in all patients with a certain tumor, or in some cases they look for particular mutations that are only present in the patient that you're treating.
Thank you. Dr. Fischer, question from Carol. Are there any circumstances where a surgical oncology fellow does melanoma surgery on their own without supervision by a training surgeon?
No. Here, I mean, we always have a supervising physician in the room. Obviously, there are graduated levels of sort of things that fellows are able to do. And again, as I mentioned, these are all surgeons who are board certified general surgeons and can do the surgery. It's not really the technical piece of it. It's sort of just being there, making sure that the steps are followed appropriately. And so at our institution, I think, Rick's trained scores of trainees. I've been doing this for 4 or 5 years now. Some surgeons actually need 2 sets of hands to do the procedure. And if we didn't have fellows, we would collaborate with other surgeons. But for all training environments, all surgery is done under the direct supervision of a faculty member.
Yeah, experience counts. So that's reassuring to hear that. Okay, Dr. Essner, you've got substantial experience in the Cancer Institute and in the cancer clinic at St. John's. Talk to us a little bit about the unique approach with multidisciplinary teams unique approach that's taken in the St. John's Cancer Institute. How does it differ from the common experience that people have in healthcare in general?
Yeah, so I think still in America, most of healthcare is still by private physicians in their own office. And so if you show up in a surgeon's office for care of your melanoma, you'll meet the surgeon, you might meet their nurse and PA, but the work is very focused on just assessing the patient in one kind of dimension. And so in the cancer center, we actually have multi-dimensions, because not only you would meet the surgeon and the nurse and PA, the working staff of the surgeon, but also Dr. Margolin sees patients like when I do or when Dr. Fischer. And so we have the medical oncology approach. There's the psychosocial approach. So we have the support, because we know that cancer is not just about removing your tumor or giving you medicine. It's about the well-being of the patient and nutrition and even the family. So in our kind of modern setting, we have everything there. Sometimes in our particular clinic setup, it's hard to believe it's all there, because this clinic physically is quite small. But we do have all the components, and we really think it's important because it provides the patient really the best in cancer care. And then finally, actually, I didn't even talk about is the geneticist. So Providence has a geneticist. She's physically not in at St. John's, but she's available. And so that's the other component of it, is what is your risk of other cancers? And what about your family? What is their risk of showing up with melanoma or other malignancy one day? So again, this is really a hands up for us that we're able to accomplish that in our setting.
And how does the social and psychological support work in the cancer clinic? You know, a diagnosis of melanoma is hugely anxiety provoking. How do we provide support for the patient and family in those circumstances?
Well, I think the first thing that happens when they show up is I believe they get a tablet in which they get a stress screening. So sometimes it's hard to tell when a patient shows up in the room with you exactly what's happening in their world. They have a new diagnosis, they're scared. Some people manifest their fear in different ways. Sometimes they get angry at the physicians and the caregivers because they're really disappointed with their diagnosis. But being able to screen people at the onset allows us to try to intervene early, and it may help the patient, get through the circumstance, which unfortunately these cancer diagnoses, even though we may operate on somebody and deem them cured, the reality of it, patients hang on to the diagnosis for the rest of their life, and they're worried about themselves and they're worried about their families. So it's really important to intervene at the onset. So I think we're really quite good at that, and certainly I hope so. And certainly if there's room for improvement, I'd be the first to listen. But I think that's really key to providing, superb care for our patients.
I've been impressed with the fact that our cancer clinic includes a psycho-oncologist, a psychiatrist specializing in behavioral challenges associated with cancer diagnosis. How do people get referred to the psycho-oncologist?
I think that any of the physicians can refer to. So number one, I think the stress screening will alert and then they make their way to the psychiatrist. And again, psychiatry doesn't mean that you're going to get some pills. It might mean that just sitting down for one session gets you through the initial event. It may be that you need counseling from somebody else or some kind of intervention in your family for the next 6 months or year. So I guess there's a number of different levels, but I think, again, the stress screening seems to be the first step. And then every once in a while, we'll even ask patients, because sometimes they'll tell you, they might tell you that they're worried about losing their job or how their kid's going to get to school if they're coming to St. John's for treatment. And so I think that having it, like you said, a psychiatrist nearby allows us to quickly get people in to get care.
Terrific. Dr. Margolin, the spectrum of disease from melanoma is quite broad. Let's talk about the worst case scenario that we have to address. What can you treat and cure melanoma if it's spread widely? And what happens if melanoma metastasizes to other organs, particularly the brain, which is in my experience as a neurosurgeon, all too common.
Yes, going backwards to just address these points in reverse, melanoma is the disease that has the highest propensity over any other malignancy to spread to the brain. And although overall we see more cases of breast and lung cancer in the brain because those diseases are far more common, within melanoma, you'll still see at least half, if not 2/3 of the patients, if you follow them for their entire lifetime, those who succumb will have developed brain metastases. However, the really good news is that in the essentially decade since we have had access to both those molecular drugs that attack the mutation cells and the immunotherapy drugs that are far more active and less toxic than prior immunotherapy drugs, we've really enjoyed a set of breakthroughs and happiness in this area that's really, incomparable in other tumor types. I would judge based on what I've seen and what I've read over that last decade, and I've been fortunate to be involved in a lot of these trials, and so was my predecessor, Dr. O'Day at the center, that around half of patients now with metastatic melanoma are curable, maybe just a little less than half with the drugs that we have. And for the other half who are not so fortunate, we continue to use clinical trials. Of course, we use clinical trials as first line. We use clinical trials as second line, and we look for new immunotherapies and new molecular drugs. The immunotherapies are a little ahead of the immunodrugs because more patients can get them and because there are more of them and they seem to work better. So there are quite a few new companies that have created new drugs that we're testing. As for the brain metastases, we basically have two approaches that we use depending on the patient's situation. If the patient has symptoms, they almost always receive a very specialized form of radiation therapy that delivers a high dose to a small area. We no longer radiate the whole brain. It doesn't really work very well. But we've also found, and I was fortunate to lead some of this work, that many of the immunotherapies that we use as frontline for metastatic melanoma actually can affect the tumors in the brain. The drugs don't really get into the brain. They're very large molecules, they're proteins, but they seem to activate the immune cells outside the brain. And then those immune cells enter the brain because they're kind of flexible and they can bend and they can shove their way through these vessels into the brain substance. And they can indeed kill the tumor cells on an immunologic basis. So we're moving forward, little steps and big steps, and all different sizes, but it's definitely going forward, and it's looking better all the time.
Well, thank you for the answer. This is a tremendous ray of hope for all kinds of cancers. We've had such tremendous success in dealing with what was almost universally a fatal disease a decade or two ago. So finally, the war on cancer is bearing fruit. We're making some big advances, and it's wonderful to see that it's happening in the area of melanoma. And thank you, Dr. Margolin, for your contributions in this area, which are acknowledged internationally. Well, there's one final question I wanted to address myself, and that is how do we fund all this work around melanoma treatment and other kinds of cancer treatments? There's several mechanisms. Critically important is the funding of clinical trials that comes from pharmaceutical companies. And that's where many of these exciting advances that Dr. Margolin was just talking about, that's where they come and actually make it to the front lines of the battle against an individual patient's cancer. Some of the basic research that shines the way towards what kind of targets we should be addressing and what is the fundamental vulnerability in a cancer cell's biology. Some of that research is done with funding from the National Institutes of Health and the National Cancer Institute, as well as from several other institutes like the non-governmental groups that fund research. And finally, a hugely important component comes from philanthropy. This comes from philanthropic foundations and from generous individuals to support many of the very early stage investigations that are even too early for the NIH to fund. These are tremendously important, and many of the training activities are supported by generous individuals, some of them grateful patients who've been treated themselves, and this is a tremendously important component. So those really are the three key avenues for funding the research that's leading to, in melanoma, cures for almost 50% of the patients with what used to be universally fatal disseminated cancer. And hopefully we're going to find that the clues we get from melanoma treatments can be generalized to breast cancer and lung cancer and colon cancer and prostate cancer and the others, so that more and more patients with what used to be hopeless progressive disease are cured and get back to their lives. So Jean, I'm going to turn it back over to you at this point. I think we've gotten some great information from our panelists. Thank you all for contributing your knowledge and experience to this session. And thanks to the audience for sending in so many interesting questions.
Thank you, Dr. Martin, and thank you to all the panelists. That really was incredibly interesting. And every year, it's amazing to me how much changes in a year's time. So it's wonderful to hear the great progress that's happened. And it's incredible to hear about St. John's part that we've had and this incredible successes that we've seen in melanoma, increased survival rates through the revolution of immunotherapy. And a lot of that was done. There's been a lot of research done at St. John's Cancer Institute. So that's, it's very exciting to be involved with this work. And we appreciate everybody being on this webinar. There's a lot of questions that we probably didn't get to. So please look out in your email. We'll be answering some of these questions for you. Those answers will come directly to you. As Dr. Martin said, we can't do this work without your support. So thank you for considering how you may help support us, this critical work. And you could go to our website and you can donate there, or you could respond to any of our emails if you're interested in donating. And I'm very happy to get back to you about that. We have 3 more webinars coming up this year in September. On the 28th of September, you'll hear about bone health during cancer treatment and the importance of vitamin D. In October, it's Breast Cancer Month, so you'll hear more about updates and what's happening in breast cancer. And then Dr. Robert McKenna will be talking about lung cancer in November. So we look forward to seeing you all on our webinars coming up. And again, thank you for being with us today.
Jean, I've got to finish on this note that I just read, texted in from Scott. Scott says, I was a patient beginning 2003, had 4 brain tumors from spread of the original melanoma, CyberKnife radiation therapy on the first 2, and Gamma Knife radiation therapy on the second 2. Then in 2016, I had immunotherapy. The melanoma returned in lungs, liver, intestines, and lymph nodes. The immunotherapy with Yervoy and Opdivo worked. And now, 20 years after the original melanoma diagnosis, I'm still here and doing well. So that's the kind of story we want to hear more and more and more, not only for melanoma, but for every kind of cancer diagnosis. And that's what all of us come to work every day to achieve. Thanks.
Thank you.